Good evening. I know everybody is very tired today. I will be talking on VELIS and the recent advances. So, when we talk about recent advances in arthroplasty, there are three T's: technique, technology, and tools. That means implants, which Hemant has already covered all the implants, right from all poly to the latest ones, like the medial pivot joint. I'll be mainly talking on the technology part of it. So, some of this will be repetition in some talks we had in the morning. So we have various shapes of legs. So putting any implant of your choice, any company, any implant in various positions is the philosophy which is evolving now. And there are various alignment philosophies which we had one session in the afternoon today. You cannot say that mechanical alignment, which is all, of course, a longest sort of a believed philosophy in knee replacement, should be the only choice for every patient. I think everybody's knee is different, and CPAC classification, which we discussed, may not be completely optimum right now, but we may have various other philosophies which will be coming in near future. And just like these bicycles, we may have different sort of biomechanics for everything. So I am today, right now, I am going to talk about functional alignment. Some of this was talked by Dr. Rajkumar in the afternoon. So this is a novel philosophy, relatively novel philosophy, which is balancing the TKR with minimal soft tissue releases. And that soft tissue release with advent of technology, it can be done throughout the range of movement. That is one thing which the technology has given us in advance. Means earlier we were used to balance the knee only in 90 degrees flexion and extension, whereas now you can see the entire range of movement and the stability with any of the robotic technology, and then you can actually see that. So whatever our earlier problems were there, like mid flexion instability and all those things, can be tackled with repositioning of the implants and adequate and judicious measured soft tissue resection or soft tissue releases. It allows the three-dimensional placement of the femoral tibial components. So it's, in a varus knee, typically it's not only a coronal plane problem, but it's a sagittal plane problem as well, and a rotational problem as well. Because most of the complex cases, what we all face, we will have bone defects, and it's even a rotational problem also, which we are unable to actually tackle, or limited understanding was there with the conventional instruments. So in functional alignment, we align the femoral tibial components in combined 3 to 6 degrees of valgus. We can actually do flexion extension of the femoral component. The rotation of the femoral component also can be achieved, and you might have heard a lot of speakers today who have said that now we as a robotic surgeon do internal rotation of femur also, and that's a really something which has shattered our old sort of beliefs that it has to be in 3 degrees of external rotation. Now, if you see the literature, then the external rotation of the femoral component ranges from 0 degrees to 9 degrees. And we were all giving, every patient 3 degrees of external rotation. So all these concepts probably will change in coming years of time. Now, since last about 8-10 years of experience with robotics, I have seen that it is not uniform 3 degrees, and hardly any time we stick to 3 degrees of this thing. Another thing is slope also. The slope of tibia also is a variable which changes in a normal in this thing, and I find the CPAC classification very much limited as far as the slope of tibia is concerned and rotation of femoral component is concerned. So I am going to show certain cases on VELIS. This is a simple case which according to some can be a unicompartmental. So in VELIS you have to, it's a very compact sort of a robotic system where it gets attached to the table, the handpiece and the robotic arm gets attached to the table. So it doesn't take a lot of space in the operation theater, unlike some other technologies which occupy huge space in the operation theater. So you don't need to do a lot of adjustments. Then you have to adjust the camera accordingly. You get this sign where you get the center of the camera which is centered to the knee joint. After that, the registration is a very fast process. You have to gently rotate the thigh in range of movement, and it marks the center of the head of the femur. Then you have to mark the malleoli. Then you take the white side line, the Akagi line. Akagi line you take from the PCL insertion to the medial 1/3 of the tibial tuberosity. So tibial rotation also can be actually marked. Then you mark the surfaces of the joint, that is the medial distal femoral condyle, lateral distal femoral posterior, and medial and lateral condyles. After that, you have this left hand lower figure. that gives you an exact notch point also. So you have to move the tracker gently on the anterior cortex of the of the femur, where it gives you the exact notch point, and then you get all these points which you reconfirm here. You get a green signal here where it shows that your mapping is absolutely not off the mark, and so you get a reconfirmation. Here, this is a system which is absolutely imageless system. So it is, some of you might have used the navigation, BrainLab navigation. So the workflow is almost similar to that, very easy workflow. And then you get, after mapping, all these dynamic values. So here on one screen, you get everything. So this will be telling us the exact tightness of the ligament. So this is in extension, this is in flexion, and you see the values here. So you can actually reposition your implants in some varus or whatever rotation, and you can open up the gaps accordingly and have a limited soft tissue release. So in functional alignment, I have generally kept 5 degrees as my borders. So I don't do any alignment which is more than 5 degrees, 2 degrees to 3 degrees on tibia and 2 degrees on femur. And rotation, I tend to be quite flexible. Rotation sometimes I have gone to 7 degrees, 8 degrees also. Only very limited cases I have done extreme kinematic alignment or unrestricted kinematic, that whatever they say, and that was a very elderly patient with a lot of comorbidities. So I thought that, repositioning, where I ended up in 9 degrees of combined varus in that particular knee. But that's about 2 years follow-up. Patient is doing well, but we don't know what happens in a longer run, like 15 years or something like that. So you have to restrict your alignment within 3 to 5 degrees of this thing. So after this screen, you get this screen where you get the gaps also, you get the cuts also, and then you get to know this thing. So here you can adjust some varus valgus, and then you get your alignment. So in this particular case, we gave 1 degree varus on the tibia, 1 degree here, and we got exactly same, without any soft tissue releases. So in a single digit deformity, like I was telling in the morning, you rarely have to release any soft tissues apart from whatever is required for the exposure and the cuts. Don't need to release the deep MCL, superficial MCL, don't have to do pie crustings, and that they are very easily doable. You have got two workflows in VELYS. One is tibia first, and where you can use the tensioner which they have actually provided. And the tensioner, helps us in assessing the ligament laxity or contractures throughout the range of movement. Some of the other technologies which I am using, you don't have a tensioner, and that is where, they tell that you give the varus valgus stress throughout the range of movement. It's very difficult to apply the uniform stress. You can easily apply a stress in extension, but beyond 60 degrees of flexion, you try to apply varus or valgus stress, and then it rotates. So it's not a uniform sort of a stress, and then the ligament assessment is not optimum. Whereas in this, if you do the tibia first in VELYS, then you can actually get the entire range of movement where equal pressure is applied to medial and lateral compartment, and you actually get to know the exact sort of status of the ligament. So here you take the tibia cut first. This is a saw-based robotic system. You have to remember that VELYS saw is quite thick blade. It has got 2 millimeter thick blade. So if you tend to measure the cuts, which I advocate always, you should measure the cuts. If you have planned for 9 mm, the cut will come as 7 mm. 2 mm will account for the saw. So you should not take a recut and go on opening it up. So after that, you tibia cut, then you put this tensioner inside, and then you assess the ligament. So here you see the assessment here. So if you want to adjust, you get a second chance to adjust in the femoral component as well. If you want to readjust it, if you want to tighten some gap on the varus on the medial side, or in medial side or lateral side in flexion also, you have got a second chance to adjust the components again. So generally our aim has to be both the ligaments, medial and lateral, they are not isometric. The tension throughout the range of movement changes. So the ligaments are a bit sort of a lax in flexion. They are tighter in extension. Lateral ligament is slightly lax. So ultimately, when you are doing a robotic, with the advantage of robotics, you should plan the lateral ligament laxity by about 1 millimeter or 2 millimeters in extension. And in flexion, you can go up to 3 to 4 millimeters of laxity also. So finally, this was in this particular case, this was after adjusting the femoral component, where I took some more varus, and this thing was there. And then after this, you just have to complete the femoral cuts and get the implant in place. So actually in VELYS, you don't have to really change your arrangements in the OT. It's very compact machine, and you can actually get the surgery done very easily. This is not having a haptic control, so the saw is not going to stop. You have to rely on your hand feel to stop where you have to do it. Another thing is that don't try to force the saw, otherwise the saw stops vibrating, and you have to be very gentle with that. You have to just guide the saw to cut the bone and stop it where there is an end point. So this was the final sort of alignment in this particular case. You can see there is slight laxity on the lateral side. This was the post-op X-ray. Another case where there was slightly more varus, and again the same things, we have adjusted it within the boundaries of 4 to 5 degrees, and you get all these sort of this thing. So here, since it is tighter in flexion, you can actually anteriorize it or change the orientation of femoral component. Femoral adjustment should not exceed more than 2 degrees, and you should get all equal gaps. That's another philosophy where you change it and get all the alignment perfectly well. You can check the cuts in all steps and validate it. If required, you can take a recut also, ranging from 1 to 2 millimeters. So it's a very sort of a user-friendly sort of a technology. So in kinematic, if you see, there are very subtle differences in all these philosophies. It's slightly confusing. So in kinematic, you tend to have a more bone resection as compared to functional alignment. So functional is what we are doing in all our practice, where minimal soft tissue or this thing which is measured, which we are doing. So restricted kinematic and this thing functional. I think functional alignment is the way to go. Thank you very much.